Well, hello and welcome to the Spinal Cord Injury Forum. My name is Heather Barnett. I am a spinal cord injury physician at the Department of Rehabilitation Medicine at the University of Washington and the director of the Northwest Regional Spinal Cord Injury System. Tonight, we are pleased to welcome Dr. Chris Crowe, who is a board-certified plastic surgeon and a UW Assistant Professor of Plastic Surgery, as well as Evan Griffis, who is an individual with a spinal cord injury. They will be presenting on upper limb function after spinal cord, restoring upper limb function after spinal cord injury with nerve transfer surgery. Welcome to Dr. Crowe and Evan, and thank you all for being here.
Good evening, everybody. My name's Chris Crowe. Thank you, Dr. Barnett, for the introduction, and thanks to the SCI Forum for inviting me to speak today. I'm going to be speaking about something that I am very passionate about, which is reconstruction of the upper extremity after spinal cord injury. And we have a special opportunity tonight as well, as Dr. Barnett mentioned. We're joined by Evan Griffis, who's going to share his journey with surgery in regards to the upper extremity and spinal cord injury. So in the next 45 minutes or so, I'm going to cover several topics related to the upper extremity and spinal cord injuries. We're going to first discuss how and why the upper extremity is involved. We're going to talk about goals of reconstruction. We'll talk about why we pursue certain surgical treatments and what's available in this day and age. We'll talk about what the surgical evaluation entails and who is a candidate for surgery. We'll talk about the surgical process itself, from preoperative, day of surgery, and postoperatively. And then we'll finish out by talking about some common procedures that a lot of you may already kind of know about. So when I was putting this together, I found myself wanting to balance the level of detail that I provided, making sure that it was really helpful for people without being overburdening. And so like Dr. Burnett said, we'll save questions for the end, and I will stay here as long as needed. If anyone is interested in further reading and some take-home material, I would recommend this nerve repair manual. And this is produced by Checkpoint Manual. I have no financial disclosure with this company, other than I think it's a really great resource. I have physical copies with me, and a PDF is also available online if you search Nerve Repair Manual. So a little bit about me. I really am now from the Seattle area. My wife and I have spent 8 years total here. It's where I did my surgical training. And now we really like to call the Pacific Northwest home. For a period of time, I moved to the colder part of the US, Rochester, Minnesota, and did my orthopedic hand and upper limb surgery fellowship. And I was fortunate there to work with a lot of patients who had brain and spinal cord injuries, and really enjoyed working with those populations, and so much so that I pursued more training and actually traveled to much warmer places. I was in Florianopolis, Brazil for several months working with a surgeon who kind of pioneered different nerve transfer techniques for both nerve injuries and spinal cord injuries. I then spent some time in Paris working with stroke and tetraplegic patients, as well as southern India. And then lastly, I did a pediatric fellowship where I worked with children who had spinal cord injuries, cerebral palsy, and various other nerve and growth conditions. And as much as I learned about surgery during this time, I really learned more about the resilience that this population has. And it was really easy to develop a passion for this line of work. So let's start by talking about the upper limb and how it's involved in spinal cord injury. So I think we all know about the importance of the hand, and even early humans know about the importance of the hand. Here on the left, you can see cave paintings found in Spain, dating back 22,000 years ago. On the right, some comically large hands discovered in Sweden from 6,000 years ago. And so even early humans knew about the importance of the hand. But don't take my word for it. A research study was done in Europe about 20 years ago of cervical or neck level injuries. And patients were asked if things could improve in different components of their life, what would make the biggest impact? And regardless of the level of injury, people overwhelmingly said hand function, because it's so tied to independence. So this is very basic, but the spinal cord lives in its kind of bony protective shell, the vertebrae, and we divide it into different regions. The neck is the cervical region, then the upper back is the thoracic region, the lower back is the lumbar region, and then the sacrum is the tailbone. And in between those vertebrae, the spinal cord gives out these nerves, and those are what control our muscles in both our arms and our legs. The cervical region is where the nerves come out and control the arms, and the lumbar region is where the nerves come out and control the legs. So when we're looking at just the arm, the nerves come out and they form this thing called the brachial plexus, which is this intricate network of nerves, and it's made up of the nerves C5, cervical 5 is its designation, C6, C7, C8, and T1. And those nerves control the upper extremity, like I said. So it's very easy to think of the analogy of different Ethernet cables coming out of a computer and controlling motor function and receiving sensory input. But that's not really what it's like. For a long time we would say, C5 controls shoulder motion, C6 controls elbow flexion and supination, which is turning the palm up, like holding a cup of soup. That's how you can remember it. C7 controls elbow extension, wrist extension, finger extension, C8 finger flexion, and T1 fine motor movement. And I think that's fine for a very kind of broad strokes interpretation of those nerves. But I think the better analogy is to think of it like an office building where you have different divisions, sales, marketing, product management, all living on different levels and coexisting. So for instance, the pectoralis major, the big chest muscle in front of our chest, is made up of all 5 levels, C5 through T1, getting input from all those nerves. The biceps on the front of the arm, which flexes the elbow, is controlled by C5 and C6. The triceps on the back of the arm, which extends the elbow, is made up of C7 and C8. And so it really isn't one function per cable or one cable per function. Instead, there are multiple muscle groups sharing input from different levels. And so this is a very busy slide. And all I meant by this slide is to show you that you have different muscle groups cascading down across the cervical and first thoracic spinal nerves, and they're all kind of overlapping, but in a predictable pattern, which is very useful for us as surgeons. So when we talk about the level and extent of injury, just on a population level, we know that the hand is affected in more than 50% of individuals with spinal cord injury. And this was derived from a study in 2023, so we know it's recent. In terms of the most common levels, the studies will vary, but they tend to show that between C4 and C6 are the most common levels, and that tends to be represented over and over again through the literature. We can classify injuries in many different ways. So people with spinal cord injury will oftentimes know their AIS grade, and this is essentially 4 to 5 different grades, which break down the level from being motor and sensory, complete, incomplete, and how strong the muscles can be. But it really doesn't tell us much about what is functioning and what's available as a donor muscle or nerve. And so in the 70s, a group of hand surgeons got together and came up with a new classification system that was based on function of the upper limb. And so that was able to guide treatment much better. And so the way that it looks is each limb receives a grade between 0 and 9. And that grade represents what last muscle is still strong and active in the patient, with grade 0 being a higher level injury and grade 9 being a lower. So what are our priorities for surgical reconstruction? Well, the first is elbow extension, the second is wrist extension, the third is pinch and release, and the fourth is grasp and release. So elbow extension. You're probably thinking, why is this so important? And Evan is showing us now his elbow extension, which is great. It's important for pushing a wheelchair. It's important for transfers, relieving pressure points in bed. I think most importantly, it's important for tabletop activities. It is what opposes the biceps and the brachialis muscles, which tend to flex the arm and really positions the hand accurately in space. In one study of individuals with spinal cord injury, they actually showed that elbow extension was the strongest predictor of self-care. So again, demonstrating how important it is. So moving along to wrist extension. Wrist extension allows for something called tenodesis-driven grasp and pinch. And so tenodesis is essentially the process by which active motion at one joint produces a passive or automatic motion at another joint. So most relevant to spinal cord injury is wrist motion and finger motion. So when the wrist flexes, the finger extends. And then when the wrist extends, the fingers flex. And that's very normal. You could do that at home, whether or not you've had a spinal cord injury. And what this does is it allows for some rudimentary pinch and grasp. The next priority is active key pinch. This is also known as lateral pinch. There's several types of pinch that we talk about, and you'll hear us say. There's pincer grasp, kind of like a crab. There's chuck pinch, which is sort of like the chuck on a drill, or we call it tripod pinch. But key pinch is the pinch between the thumb pad and the side of the index finger. And that's very important, again, for holding a key, which is why we call it key pinch, but just manipulating small objects in general. That can be things like using a remote control, using a smartphone, performing self-catheterization. Next is grasp. Grasp has been shown to be both physically and psychologically important. We can achieve this either through tenodesis, which is a passive wrist extension and have grasp, or we can do it actively through working tendons and nerves and muscles. So what are the varieties of treatment options that we have at our disposal? So a little history before I get into that. In the mid-1900s, there was virtually no literature, no scientific studies that showed any sort of outcomes for doing upper extremity surgery in spinal cord patients. It wasn't until the 1940s some surgeons started publishing results of treatment of polio patients. And so that's where a lot of the early literature came from. And for a long time, there was a very pessimistic view about what surgery could achieve in the spinal cord population. And likely this is because procedures were misapplied to a patient that did not have polio. And so it was just a different patient entirely. It wasn't until the 1960s and 1970s that a lot of reports of successful surgery started coming out. And those were categorized into three major categories that we still use today: tendon transfer, tenodesis, and joint fusions. So tendon transfer, it is what it sounds like. It's moving a working tendon or muscle to a non-working tendon and muscle to produce new motion or to stabilize a joint. And so in this figure here on the left, I show kind of a beefy, healthy pink muscle, which is the working muscle and tendon. And then just to its right is the more pale gray non-working muscle. And then you can see in the right figure that the working tendon muscle has been woven and sewn into that non-working tendon to produce new motion. So the tendon transfer principles were established in the 1940s, and we still use those today. The first is that the donor has to be expendable. You don't want to take a muscle or tendon that you need to function. Next is adequate strength and control. Obviously, you want to be able to control the working muscle and have good strength if you're going to produce new motion. The next one is a little bit more biomechanical, a straight line of pull. That conserves energy. If you're making 90 or 180 degree bends, obviously you're going to lose some of that power, so it's not ideal. No contractures that prevent it from working. So this is kind of like replacing the engine on your car if your wheels are rusted. You want to make sure that everything's greased and moving nicely before you put in that new engine. One muscle, one function. So that means that when you transfer a tendon, it's just going to perform one function. We sometimes bend this rule when we need to, and sometimes we have things perform more than one function. And then synergistic motion. This is a fancy way of saying that the brain is going to naturally adapt to the new function. It's not something funky like I have to move my shoulder up to wiggle my pinky. So once the tendon transfer is done, the tendon is weaved together and then it's sewn in place with some non-absorbable sutures. And in general, patients have to be splinted or casted for 4 to 6 weeks to allow the tendons to heal. You can see some examples here of how those tendons are weaved together. You have this bulky, what's called a pulver taft weave, where you weave the tendon multiple times and sew it at different places. Or you have kind of a side-to-side weave, and I prefer the side-to-side. Personally, I think it just looks better and it gives a smoother appearance of the tendon. So after the incision and repair site have healed, a removable splint is fabricated, and then therapy or motion is started. So you start out with a splint, which looks like something on the left, and that's usually made with plaster that just goes on one side of the hand and wrist and forearm. And then after 2 weeks, once all the swelling has gone down, we can transition to something a little bit more firm, which is a cast, and it goes all the way around the arm. And then once you come out of that, you would go into a removable splint, which is custom fit, and it can be easily removed for hygiene and exercises at home. But that's not it. Once the tendon has healed, you then have to retrain your brain to fire that new muscle. And so therapists are very critical in this, and I thank any therapists that are joining us because you make us look good as surgeons, and really it's you that's doing the hard work. Then there are tenodesis procedures. Now, I'll go back to what tenodesis is. It's this active motion that produces a new automatic motion like the wrist and fingers, and we can kind of capitalize on that automatic motion by retensioning the tendons that control the fingers. So if we tighten those up, when the wrist flexes, you're really going to extend your fingers because they're tighter now. And we can do that by sewing them to stout tissue around the wrist. We can do that by kind of weaving them through bone tunnels, but we make sure that it's nice and tight before going ahead with motion. And then arthrodesis, which is a fancy way of saying joint fusion. So this is just removing the joints and allowing the bones to heal on either side. So what you do is you make an incision, you remove the cartilage on either side of the bones that you want to fuse, you position them just as you want, and you fuse them together. And you're probably thinking, we want more motion. Why would we take motion away? Well, oftentimes we do this when the joints are preventing good motion. So the joint is out of place, it's maybe off to the side, or it's dislocated and it's not working efficiently. So by fusing it, the muscles that surround that joint can then work to power the other joints more effectively. So like I said, it does require an incision so that the bone edges can be prepared, and it requires a splint or a cast for 4 to 6 weeks while the bone heals, like a fracture would or a broken bone. You can see this is just an example of a wrist fusion that we oftentimes will not do any wrist fusions in spinal cord patients unless necessary, just because we really want to preserve wrist motion for tenodesis. So what's new? And the answer to that is nerve transfers. We've used nerve transfers for several decades in patients that have had nerve injuries closer to the fingers, outside of the neck and down into the armpit and the elbow and forearm and hand. And they're becoming increasingly common. I just looked up the other day nerve transfer and spinal cord in one of our medical databases, and you can see in the last 10 years, studies have quadrupled in number in the last 10 years, reaching nearly 30 studies per year on nerve transfer and spinal cord. So what is a nerve transfer? This is connecting a working nerve, which is above the level of the spinal injury, to a non-working nerve below the level of the spinal injury. And it doesn't mean that it's connected in the neck, it's down further in the arm, but those nerves are derived from a higher level and then a lower level on the spinal cord. So what does this look like? Using our same kind of diagram as the tendon, you can see on the left is that working muscle and nerve, which is nice and bright yellow and bright pink. And then on the right side is the non-working nerve and muscle, which is a little bit more pale and gray. So you divide the working nerve and you flip it over and you reconnect it to the non-working nerve to repower that muscle. So it's a little bit like rewiring the system. But that's kind of where the analogy ends, and I'll go into detail a little bit about this later. Unlike tendon transfers, the nerve is connected ideally without any tension, so it's nice and loose, and so no strict immobilization is required, and we just ensure that the skin has healed. It depends on how tight that connection is. Some people use a sling, some people feel that it's okay to not use a sling, and that really just depends on the specific surgeon and the specific surgery. So, going back to the analogy of rewiring the system, unlike an electrical system where once those wires are spliced and you turn on the light and it works immediately, the nerve is biologic and it has to regrow to the muscle. And so that takes a long time. It grows at about 1 millimeter a day after it's gotten over that initial shock of being cut and transferred. And so that's about a thin piece of pencil lead a day. So it can take 6 to 12 months before the nerve even reaches the muscle. and develops some noticeable strength. And I like to say that it's really not like a light switch where once it reaches the muscle, boom, you have strength immediately. It's a dimmer switch. Once it reaches the muscle, there's sprouting that occurs, and over the next year or two, it's going to slowly ramp up over time. So I tell patients we wait until 2 years to make any conclusions about what the nerve transfer has done. So similar to tendon transfers, you have to retrain the brain to activate new muscles. And again, therapists are critical in this process. And sometimes some of these nerve transfers are not as intuitive as others, so we have to come up with really unique strategies to get people to feel like they're activating it naturally. So the big question is, are nerve transfers time sensitive? And I feel like this is probably the question that I get asked the most by patients and providers and therapists alike. And I wish I could just say yes or no, but that would make it very easy to find online. And unfortunately, it just depends. So I mentioned that I'm going to try to make this not super technical. And so I'm going to simplify some concepts. And if there are any neurologists listening in, they're probably rolling their eyes right now. I'm lucky that I can't see you right now. There are two nerves between the brain and the muscle, an upper nerve and a lower nerve. The upper nerve goes from the brain down into the spinal cord, and then the lower nerve goes from the spinal cord to the muscle. And there's a junction of those two nerves where the signal is transmitted, right where the nerve exits the spinal cord. So when only the upper nerve is injured, that would be below the level of the injury, so far below where the injury has occurred, where just the upper nerve is injured, there is no muscle atrophy. If the lower motor nerve is also injured, then the muscle will atrophy because the muscle has now lost its constant signal to keep it active, and so it will gradually atrophy over the next 12 months or so. So I remind you again that the nerve grows at 1 millimeter a day, and that's how much time it needs to reach the muscle. So it takes about 6 to 12 months to reach that muscle. So we are given a window of time when their lower motor nerve is involved to act, because we don't want that muscle to permanently atrophy. So that's where the surgical evaluation becomes very, very timely and critical. So I think that's a good natural transition to what the surgical evaluation is. Now, if you're like me, you hear the word medical or surgical evaluation and you think someone with a white coat is going to walk into the room, they're going to move my joints, they're going to say this or that, and then they're going to walk out of the room. It really is much more than that. It's really about understanding the individual. It's not just an exam. The first part of the evaluation involves really defining and hammering down the timeline of the spinal cord injury. We want to know what, when, where, why, how. We want to know any recovery that's occurred since the injury. We want to know the presence of other injuries like broken bones or other nerve injuries that are closer to the hand. We want to know about current functional status. How do you feed? How do you clean? How do you use a wheelchair? What do you like to do? And what are the strategies that you use to accomplish those things? We obviously want to talk about that so that if something is downgraded, it's not a critical downgrade to achieve new motion. Then we talk about your living situation and social support, which are very critical. And in doing all those things, both us, the surgeons, and the rehab providers and the therapists and the patient and their caregivers and their family and friends come up with any barriers to rehabilitation that we can identify and address those. Now comes the more objective part, which is a thorough and repeated clinical examination. So that means doing the exam multiple times and being sure we know what's strong, what's not, what's under voluntary control, what's not. And that can include assessments by the therapists. And sometimes it includes electrodiagnostic studies like EMG and sometimes other imaging. And again, all of this is done in order to put each limb somewhere on this international classification. And what this does is it tells us what we have available to donate. So in the exam, we're going to test range of motion, active and passive range of motion, so what you can do and what I can do. We're going to determine any contracture or spasticity that is present. And then we're going to test muscle strength to know what might be donors for tendon or muscle transfer. And sometimes we can't really parse out what muscles are available. Sometimes multiple muscles do the same thing, and we need to know, is there two or one? Because it's very important to know that before we take one of them. So EMG, this electromyography, can be very, very, very helpful in knowing, in kind of showing us what muscles are available. And I know Evan will talk about this a little bit and his experience with it. It's not a fan favorite, but as long as there's a really specific question asked, I think it can be helpful. So when is the ideal time to have a surgical evaluation? I think there's really two answers to this. For new injuries, it's best to see a multidisciplinary team at 3 and 6 months after injury. And this is all based around that muscle atrophy timeline and making decisions around nerve transfer. And then for older injuries, really any time. We have tendon transfers available, and we can work those up at any point in time. So the surgical timeline, what does this all look like? So the preoperative timeline. You meet the surgical team, you meet any other providers that are there at the multidisciplinary meetings, and you have an exam. And then some time later, there's a repeat assessment to see how things have changed. If any strategies have employed, we see how function is after that. And then we potentially obtain an EMG at some point. And then we get a therapy evaluation to make sure everything is in line for doing surgery. And then if chosen, we proceed with getting surgery scheduled. On the day of surgery, there's nothing to eat or drink after midnight before surgery, and that's to keep your stomach empty, and as a tube will probably need to be placed in the throat to breathe for you. You come to the hospital early, you meet the entire surgical OR team, including the anesthesiologist, and at that point the anesthesiologist will talk about the different types of anesthesia that may or may not be available. General anesthesia refers to a full anesthetic with a breathing tube. Sometimes we can get away with something called a nerve block, where the limb is made numb if there is any sensation there, and there's some light sedation to keep people comfortable and free of intense boredom while we're working. Then surgery starts, and it lasts anywhere from 1 to 4 hours, depending on what we have planned. If only nerve transfers are done, typically just some soft bandages are placed. If anything else is done, like tendon or bone work, then a splint is placed. Whether or not you go home after surgery or the next day really depends on multiple factors. It depends on other health conditions, it depends on comfort and pain level, and sometimes social things like how far a drive might be. After surgery, pain medications are prescribed. Narcotic pain medications are often necessary for a period of time. And then there are nerve-specific medications that you may or may not already be on, like gabapentin or pregabalin. And then Tylenol and ibuprofen can go a long ways as well. And then at a 2-week appointment, we check the incision. We exchange the splint for a cast for those tendon and bone procedures to make sure that we're not letting things loosen up or not heal. And then at the 4 to 8 week window, depending on what type of procedure was done, we remove that cast, we get therapy started and fabricate a removable splint. After the 8 to 12 week mark, we can really get strengthening exercises going and really begin to work those muscles. For nerve transfer, passive motion can start pretty soon right after surgery, as soon as the skin has healed. So now I'm going to move into some common procedures, and some of these may be familiar to both individuals with spinal cord injuries as well as therapists and other providers. A disclaimer for this, there are going to be some operative photographs in this. If you are squeamish or you don't like to see dissections like that, you can always just look down, close your eyes, and there's no problem, and I'll continue to talk and kind of describe what I'm showing. So elbow extension, that's a top priority, as I mentioned, if it's absent or inadequate, and it can be different in each arm. Again, it's important for positioning the hand in space. It's important for driving a wheelchair, performing transfers, and offloading pressure. It's not just important for reaching overhead to grab something out of a shelf, like I said. It's just so important for tabletop activities, and that's why I think it's so critical. So we have both nerve and tendon transfer options available. For nerve transfer, the big one is called a posterior deltoid or posterior axillary nerve transfer to the triceps nerve. And that's kind of a fancy way of saying we're going to take part of the nerve that goes to the big round muscle on the shoulder, the deltoid, and we're going to move it to the triceps, which extends the elbow. And that's sometimes done through an incision in the armpit. It's sometimes done an incision on the back of the arm. And then tendon transfer options, we have kind of the tendon transfer equivalent of that first one, where we leave the nerve intact to the back half, the posterior part of that deltoid muscle, but we detach the tendon and we elongate the tendon down to the triceps. So it's staying right where it is, but now it's acting to do new motion to extend the arm. And then there is also a biceps, which is the flexor muscle on the elbow, on the front of the arm, which can be rerouted to the back of the arm to produce elbow extension. So kind of using it to do the opposite of what it normally does. So up next is just an illustration. It's not a photograph. So this is what the nerve transfer looks like. We find those nerves that go to the back portion of the deltoid muscle. We divide them, which is that hashed line you can see on those nerves, and then we divide what's going to the triceps muscle and we connect them. And when we do nerve transfers, sometimes we use suture, which is smaller than a human hair. It's very, very fine suture. It's so easy to lose track of it. Or sometimes we just glue them together using a biologic glue. If they're in good position, glue can go a long way, and if they're loose enough, it's the same as sutures. So what about those tendon transfer options? So the first one, the deltoid to triceps transfer, is just like I was mentioning. You leave that nerve intact. You take the back half of the deltoid muscle off of the arm bone, which is the humerus. You use a tendon graft. So you can either use your own tendon, which would be an autograft, or you can use cadaveric, so a dead person's tendon that has had all the cells removed and all the immunogenic things removed from it so that your body accepts it. And you can use that to make the tendon longer and attach that to the triceps down near the elbow. And then on the right, I show the biceps to triceps transfer. This is very popular and is a preferred technique for doing tendon transfer for elbow extension in my hands. And so you take off the biceps tendon, which you can sometimes feel if you make a flexed arm and you feel down into the elbow crease. You can kind of feel a tight structure there. That's the biceps tendon. And we move that down on the inner part of the arm to the triceps right here. You don't need any graft for that. The biceps tendon is long enough. In both of these procedures, you have to be splinted in full extension for nearly 6 weeks. And then, I know, it's brutal. And then that comes off and we gradually allow more and more extension so that we don't inadvertently loosen that connection. So it is a long recovery. Okay, sorry about that. So we're going to now show some photos of actual surgery. So if anyone is squeamish, feel free to look away. So this is what a deltoid to triceps tendon transfer looks like. So we're looking at the patient face down on the operating room table, and the arm is spread out across a hand table here. So that's what you're seeing, is we're kind of looking up the barrel from the hand up towards the shoulder. So that's what we're seeing. And so you can see that we have an incision at the shoulder, which is identifying that back half of the deltoid muscle. The second panel is showing the posterior or the back half of the deltoid muscle, all dissected free with its short tendon there, which is gripped with a metal instrument. And you can see that's not going to reach all the way down to the elbow. That's too short. So in this case, a cadaveric tendon was used, which is what's shown in the third panel. So it's sewn in place to the muscle and the tendon there and secured. And you can see how long that is now. And then we're looking at a close-up of the elbow on that fourth and final panel where everything is sewn in place. And at this point, it's very, very, very critical to keep the arm extended so that it's as tight as possible. All right, another operative photograph coming up. This is a biceps to triceps tendon transfer. The biceps muscle is taken off on the front half of the arm. So instead of being face down, this is now the patient is face up, and we're kind of looking at the front of the arm here. So you can see the biceps muscle with that nice long tendon, which is then taken and routed around the inner arm there, which is the second panel. You can see now we have an incision on the back, and that tendon is coming through the incision on the back and now providing elbow extension instead of flexion. And then now we're looking at the back of the arm. So now the arm is kind of up like this, and we're looking at the back of the elbow. And so the triceps tendon is isolated there, and you can see the long biceps tendon going through it. And so that's sewn in place with multiple sutures, again, in full extension to ensure that it doesn't loosen over time. All right, so next is wrist extension. So this is a very high priority if it's absent or inadequate, because tenodesis produces grasp and release. So the flexion of the wrist produces release of the fingers and extension of the wrist produces some rudimentary grasp and pinch. It is critical if it's not there. So we can achieve this again in a few different ways. There are nerve transfer options, and then there are tendon transfer options. The nerve transfer option is to take the supinator nerve. So the supinator muscle, again, is the muscle that turns the palm up, like holding a cup of soup. And it is a fairly expendable muscle, and it tends to be very high in the spinal cord, which is incredible because it's a great donor and we can use it in a lot of patients. One thing to consider is that we don't want to take the supinator in both arms if we have done biceps to triceps transfer. And the reason for that is that the biceps is also a very strong supinator. So if you remove both supinators from both arms, both hands are going to be down. And that is not very great for eating or bringing anything to your mouth. So we always try to leave one intact if a biceps is going to be sacrificed in both arms. If the biceps is going to be left in place in one arm, then that's great, and then you have both available to you. For tendon transfer, we use a muscle called the brachioradialis often, and this is an accessory elbow flexor. This is an extra elbow flexor, and you can sometimes feel it on the thumb side of the forearm up near the elbow. If you try to make a firm flex, you can kind of feel that muscle and toggle it side to side. And so we transfer that to the centralmost wrist extensor, and we designate that ECRB. It stands for this long Latin word, which I won't get into, but that's what we transfer it to if it's available. So nerve transfer options, this is a view of the muscles below the elbow with obviously all the skin kind of made transparent. You can see here there are some purple arrows showing the branch to the supinator, which turns the palm up, and then to that ECRB, which is the centralmost wrist extensor. And fortunately, those are very close together, and so you don't have to dissect the nerve very far to get them to reach. So what about that tendon transfer for wrist extension? So on the thumb side of the forearm, you can see that the brachioradialis muscle is taken and it's woven into that same central wrist extensor. So coming up next is another intraoperative photo, so warning. All right, so you can see that an incision on that thumb side of the forearm has been made. The muscle of the brachioradialis has been dissected, and it's in the grasp of that pinching instrument that's pulling it towards the central wrist extensor, which is being held up by another metal instrument there. And so you can just sew those in tightly in about 30 degrees of wrist extension. All right, so next up is key pinch. So if wrist extension is already present, then we have more options to use what we would have used to reconstruct wrist extension for pinch. So more tendon and nerve available. You're probably seeing a theme by now that there are nerve transfers and tendon transfer options for all these functions. So for nerve transfer, again, supinator, which is this common donor nerve and muscle, turns the palm up. We can transfer that to the anterior interosseous nerve, AIN as it's designated, for thumb and finger flexion. And it's because that nerve does both of those things. It supplies muscles that do both. And then there's a tendon transfer option, which is to take that brachioradialis, that extra elbow flexor, and move that to the thumb flexor, the FPL, or flexor pollicis longus, which flexes the very last joint in the thumb. And sometimes we pair that with a fusion of that last joint so that all of the motion comes through all the other joints and is more of a pinch rather than just curling up at the top there. All right, so what about nerve transfers for pinch? So this is that supinator to AIN, or anterior interosseous nerve, for thumb and finger flexion. So the incision here is in the front of the elbow and the forearm. We find the nerve to the supinator, which is shown here in the leftmost panel. We dissect that out, which is in the middle panel, and then we connect the nerve of the supinator to the AIN. So I'll show you what that looks like in an actual patient. So another operative photo coming up. So you can see here the purple is showing the nerves to the supinator muscle, which are these kind of little tiny branches that come off of the larger radial nerve and go to the muscle. So we take those off, and then you can see the anterior interosseous nerve is the more plump looking one, which is designated by the number 1. And then we connect those under no tension. So you can see in this photograph, those are nice and loose. Those aren't going anywhere. So what tendon transfers do we have for pinch? It's the brachioradialis muscle to the FPL again, and so very similar, an incision on kind of the front or thumb side of the arm that allows that muscle to be harvested and then routed into the FPL muscle so that the thumb can pinch. All right, another operative photograph coming up. So again, very similar concept. The brachioradialis muscle is going through the tendon that controls the thumb, and you can see the tension is set so that when the wrist is extended, the thumb is nice and firm against the side of the index finger there. All right, we're coming up towards the end of it here. So grasp, our final priority. Flexion of the fingers for grip strength. So this is for grasping much heavier objects. And so when pinch is already present or it's reconstructible through other means, we can prioritize grasp. And again, there are nerve transfers. We can do that supinator to anterior interosseous nerve to do both functions, both thumb and finger flexion. And we have a tendon transfer function, which is to use an extra wrist extensor, if you have multiple of them, to transfer it to the flexor digitorum profundus, which is the finger flexors. So all 4 fingers have one of these tendons that go to them, and we can transfer to all of them. So this is just an illustration here. Again, same for pinch. For nerve transfer, we just dissect out the nerves, connect them, put a little glue on them under no tension, let the skin heal, and you're good. For tendon transfer, what we do first is we set the cascade of the fingers. So we make sure that it's a very normal appearing cascade of the fingers coming down so that you can pinch nicely on it. And then after that's done and we've put some sutures through all the tendons, then we weave that extra wrist extensor through all of the tendons, and we know that it's not going to pull on one more than the other. So that is all I have. And so I have a few takeaway points for everyone. And these are kind of broad. It really does take a whole team to come up with a surgical plan, not just a surgeon. The rehab medicine providers are critical. The therapists are critical. This is why we make decisions as a team with the patient and their family. There are lots of options available, even in older injuries. Nerve transfers tend to be time sensitive. There are some conditions in which they're not, but it is a promising technique and can really give more precise control, I believe, in patients that undergo those procedures. Tendon transfers and joint fusions are good standbys. You do have to have a cast for those, so there is a temporary downgrade in function while that arm is in a cast and immobilized, and so that can be a frustrating part of the recovery. So thank you to everyone who's both here live and tuned in on Zoom. At this point, I'll ask Evan to come up, and we'll hear a little bit about his experience with all this. As Dr. Barnett said, I'd like to welcome Evan Griffis, and he had his nerve-based procedures about 9 months ago, and that's sort of the level of detail that I'll leave it for now. I'll let him tell his own story. So why don't we just kind of start with where you are and how you got here.
Yeah, absolutely. So my name is Evan, like I've been introduced, and I was injured a year and a half ago. I'm a C6. Asia A was my classification, so I was a complete injury. And my introduction to nerve transfer surgeries was probably right at the very beginning of becoming injured. My initial emergency room doctors even mentioned, don't lose hope. There's cool surgeries out there, and something might be possible for you. My occupational therapist was the first person to recommend the nerve transfer surgeries for me in an outpatient setting, and things started moving very quickly from that point forward. I think it was very early February when I was scheduled for my nerve study. So I had my nerve study done very early February, and like Chris said, it's really painful. It was a really bad time, but it was worthwhile. It was a couple of hours, and it gave me an answer almost definitively about whether or not these surgeries would be an option for me. At that time in February, I was already 9 months post spinal cord injury, and so I knew that or at least I had heard that this was a little bit more time sensitive, and that ideally I needed to get in as soon as possible to see what options I had for surgery. The results that I had showed, I guess, some lower neuron damage,
Right.
which you
Very
know
good, very good,
about.
yeah,
I
yeah.
know everything about, of course, as well.
Yeah.
Expert myself.
Yeah.
And because of that, they recommended surgery right away as like, if you're going to do it, let's make some choices soon. I met with the surgery team, and a lot of the discussion we had pre-surgery was about what's my current situation with tenodesis, with transfers, with my ADLs, like you mentioned, everything about can I afford to sacrifice the donor nerves, even temporarily. And at the time, I considered those risks, but I couldn't see a downside to the surgeries. I was really optimistic after speaking with the surgeons initially that any bit of grip or extension I could receive from a surgical transfer was going to benefit me. So I signed up, and so we started with the right arm. I had 3 surgeries done in one that day. They did the ones that you talked about.
Yeah.
How convenient.
Right. So the posterior deltoid
Yep.
to triceps nerve transfer for elbow extension.
Yep.
And then you had a supinator to AIN, or in this hand was it?
I'll pull it up.
To PIN for finger extension.
I had a note for you. Supinator to PIN.
To PIN. So that's for finger extension.
Oh, for this. And then ECR to AIN for closing.
So that extra wrist extensor for finger flexion and thumb flexion. Yeah.
So my right arm is now 6 months post-surgery, right? I had this surgery March 5th. So just starting to see some results, but I'm already thrilled.
Yeah.
I'm a really happy customer. I know that I'm going to share more about between now and then, but zooming ahead, I'm really thrilled.
Yeah.
You know, this was a really difficult year of surgical recovery, but the outcomes have been really positive for me. So when I had scheduled those surgeries, I was trying to connect with other folks in the spinal cord community about who had done other nerve transfers to get their kind of feedback, and I didn't find a lot of people, unfortunately. So I kind of had to go off of the recommendation of my surgeons and thinking really about what I could sacrifice. Took a lot of pain medication the first few weeks, like you mentioned. I was also prescribed a sling. I was in an elbow sling for 3 weeks, and I think that personally, the most difficult part of the surgery was maybe not the physical pain in the recovery, but just the psychological pain of becoming almost re-disabled is what it felt like. I knew that it would be just a couple of weeks of wearing the sling and only a couple of weeks of being in pain, but to go from, I was already 9 months post-injury. I was really learning my body. I was learning how much assistance I needed to do a transfer. I was getting good at tenodesis, working with Leslie and Jordan at Harborview, and it felt like a lot to sacrifice once I had that initial surgery, and I could no longer flip my wrist.
Right.
I could no longer just even holding my own toothbrush was impossible at that point. So everything switched to my other side. At the time, my right arm was my less dominant hand. And so I thought it was smart to schedule my surgeries that way so that I could be more proficient with my left side anyways. But gosh, even just being in a sling for a couple of weeks, it really took a toll. It really took a toll for sure. And then you don't have the added benefit of seeing results,
Yeah.
like you said. So I had to just hope and wait that this was going to click for me. After the 3-week checkup with my surgeon, they immediately referred me back to the hand clinic. So I started working with another occupational therapist in the hand clinic, and they really boot camped me right at the start. So I took the sling out, and immediately I was doing this motion. I was doing some supination exercises. We're trying to do shoulder extension or elbow extension rather, and all of the rehab was so painful.
Yeah.
Also, for a really long time, it's just very weird to not be able to do things. And with so much practice, I can now do these things without second thought again.
Right.
So it took a while.
What was your mindset when you first started therapy? Was that kind of like the lowest point, or would you say that being able to be out of the sling and start to move a little bit more kind of gave you a little bit more momentum?
Yeah, the latter for sure. I think the first few weeks were way darker and harder because I didn't know what to expect. Once I started actually exercising again with my hands, it gave me some encouragement that, okay, the team knows what they're talking about. This wasn't all for nothing. The pain, the pain had really subsided by that 3-week mark. Momentum is a good word for it.
You described kind of this, having trouble finding people outside of the surgical field who had this stuff done and getting that outside perspective. So in a way, it was kind of like a leap of faith, would you say?
Yeah.
Like, what would have changed if you had, been able to talk to people who had procedures and had both good or negative things to say about it?
Yeah, a presentation like this would have helped, I think, too. I really didn't know the difference between a nerve transfer versus tendon transfer. So when I did talk to other quadriplegics, it was people were misunderstanding me, and they thought that I was only speaking about tendon transfers. I am of the perspective that I'd like to exhaust any option I have for any sort of recovery potentially. And so when I was being informed about these surgeries, plus a sprinkle of time sensitivity, it made the decision kind of quick for me. I wish that I had found more quads to warn me about how difficult it would be those first few weeks. I'm really fortunate that a lot of my care is very consistent at home with my family, and so not being able to transfer myself didn't make a huge difference. I wasn't living independently already. So I think I was a pretty good candidate in that respect. I didn't have maybe a lot to lose. I'm not working currently, so I didn't have a career to interrupt. It made my decision kind of easy. I'm now very enthusiastic about recommending these surgeries to other newly injured folks I meet, but I do really warn them that that the pain and suffering is going to be a tough wave on top of you're in your first year adjusting to a spinal cord injury. So it's not like at that 9-month mark I was already happy and ready to go. This was really just like another piece of what my first year of recovery looked like.
I think going back to what you said, it's so nice to get that perspective from somebody who's lived it. It's one thing to just have a surgeon tell you, well, there's going to be a setback, blah, 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 and things are going to be okay, don't worry. And it's another thing to say, let's talk about that setback. Let's pause for a second and really think about what it's like. And we as surgeons can always be better about that, I think.
They did offer me a rehab psychologist in the meantime, and at that moment, I kind of scoffed and thought, no, I've already been through a lot this year. I know who I need to talk to, but wearing the sling, who knew that would be like the hardest part of the recovery?
Yeah. So you mentioned the EMG. And being kind of a surprise and more painful than you anticipated. Tell us a little bit more about the process and maybe what you would have liked to have known beforehand.
Sure. Well, because I hadn't met with the surgical team before, that my referrals just happened so quickly that one day I just saw nerve study was on my chart, and so I showed up and I had no idea what I was going into. It worked out. I wasn't going to back out at that point, but I think I needed at least one consultation visit with somebody somewhere that would have warned me, because I thought nerve study up until that point. I had met with people who were doing physical examinations of my strength on wrist mostly. So I had no idea I was being probed that day. It was just kind of a surprise. But when I showed up for that appointment, the technician said, like, "Oh, I'm so glad that you're doing this. My last appointment walked out. She couldn't handle the pain." So that was like set the mood. It was really intense. But I didn't. It was already one of those like, well, I'm here for this reason. Let's get an answer before I rule myself out of having surgical options. Once we got started, it became manageable. It's about as rough as getting a tattoo, I think, from my perspective. But sitting back and letting, knowing that I was going to have an answer by the end of the day was a good motivation to like continue the whole EMG. Yeah, brutal.
Yeah. So you mentioned a little bit about support at home and everything.
Yeah.
Tell us a little bit about how that played into before surgery and then after surgery.
Sure. I would say that before surgery and after my rehab stay at Harborview, by that point we had a really good routine set up. We were kind of comfortable with what parts of my daily activity I was doing by myself independently and what my parents helped me with. And so there wasn't a huge change to the status quo until the first few weeks of recovery. And then it became, I was suddenly requiring a lot more assistance in my showering and toileting and everything else that I could otherwise have done a little bit more by myself. Since then, I think that we've definitely passed in terms of my independence at home. I'm already more capable than I was pre-surgery, so that's great.
Yeah.
That's huge for me. It started with I guess my most prominent small example was the first time that I could open my wrist, my fingers enough to get my hand around a cup and like bring a cup off the table one-handed, because for a lot of quads I'm using the palms of my hands and I'm risking my balance to try to pull something towards me. So to be able to one-handed reach and then close enough around the lid or around the surface to get, oh my gosh, like changer. 2 days ago, we were having lunch and my key pinch, is that what you called it?
Yeah.
It's almost good enough. It's almost good enough. It's not quite good enough, but it's almost good enough to eat an artichoke leaf.
We talked about this.
I talked about it.
Yeah.
But I can hold things one-handed now in this pinch, and I couldn't have done that with tenodesis alone. So it's credit. And okay, those are really small examples, but the good one is that I can almost transfer independently.
Yeah.
We're working on it. I know Leslie was on this call. It's almost just like my tricep it's waking up.
Yeah.
It's starting to do something. It's starting to offer me some consistent support for what is a basic and necessary. Like that was the goal. That was goal number one.
Right.
Yeah.
It really is that kind of like dimmer switch, and I think you're starting to hit the base value on that dimmer switch. So I think there's a lot of great things ahead. So now remind me, Evan, you were right-handed before? Yes. Okay. And your left side, at least initially, became the more functional side.
Yes.
So talk me through how that kind of affected your day-to-day life, both before surgery and then after surgery.
That is all true. It's very weird, but my brain automatically switched. But like almost immediately after becoming disabled, I just everything was easier on my left arm initially. I think that it had something to do with the preserved strength of my tricep.
Yeah.
You know, it just felt more. It just felt that I could do more with my left hand from my fingers to my tricep. I could just, it was a stronger side for me. I thought that was cool, and I thought that was permanent. But now, you know, I had my my left nerve transfers 6 weeks after my right arm surgeries, and so I know that there's a bit of a lag difference, and we're still at the beginning of the dimmer switch. But I'm already resorting now to using my right hand for things
Yeah.
again that I've been using my left side for the first year post injury. I've been left-handed, and now I'm relying more on my
Yeah.
right hand to do things. Mostly it's the key pinch. So excited to see the
Right.
more results on my left side, but yeah, it was actually a way easier, smoother transition to just becoming left-handed.
Yeah.
I liked it, but now I feel very ambidextrous.
Yeah, that's
I notice I'm reaching for things. It almost has more to do with what side of the chair is it on? Like, do I have more room to reach?
Yeah, yeah.
But I do feel pretty fully ambidextrous.
More
at this point.
circumstantial than
Yeah,
anything.
yeah. They're pretty consistent. My ability on each hand is
Yeah.
pretty consistent now.
Yeah. That's great. Well, do you have anything else to kind of share with people here and people watching?
I was really thankful to my surgeons. Post first surgery, especially, the discussion around pain was really difficult because I didn't know how much was normal, and I didn't know how much was related to my daily cocktail of nerve medication, baclofen, everything
Right.
that was already mixed in. I wasn't sure what to ask for, what was appropriate, and so I just was really thankful that my surgeons were responsive to the request to tailor and to make some changes. So not only was the oxycodone really helpful, but then switching from gabapentin to pregabalin was a big game changer for
Yeah.
me. I think the getting into the hand clinic right away to do the exercises, I personally needed to be kicked in the butt a little bit, and having 3 really hard, dark weeks of like painful recoveries, turning that very quickly into okay, sling is off, let's get those hands working
Right.
now. It became a new goal, so I wasn't really managing. It was just funny because in the morning that day, I'm still in the sling and I'm thinking I need to protect everything very closely, and then in the afternoon the sling is off and I'm suddenly doing all these exercises. So it was painful all over again, but I needed the reset, and I'm thankful for the OTs that I worked with
Yeah.
to push that for me.
Yeah. And it sounds like there might be one on the call now.
Yeah. Thanks, Leslie.
Yeah. Wonderful.
That's all I've got, I think.
Yeah. Well, that's great. Thank
Maybe
you
we
so much
can-
for sharing your perspective.
Yeah.
Yeah, thank you both so much. That was fantastic. I think we can go ahead and take some questions if people are have any questions. I certainly have questions if we don't have any from the group. But a question that I'm still remembering that I asked you at some point, Evan, and maybe Dr. Crowe will have some insight on this. You did both arms, and you did kind of one, waited a little while, and then did the other one, and I wanted to know how you guys think about whether you do both sides or one side, and what the gap is between doing that.
What did you think?
I think that my initial consultation, they wanted to schedule my left surgery 4 weeks after my right arm. And then due to my own personal schedule, we made it 6 weeks. And I think there's no way I would have been ready at 4 weeks. But I also think that if I had waited much longer, I would have had more second thoughts about a left side too.
Right.
I'm really glad that I did both sides, and this timing made it feel like I was knocking it out. But I would say that, you know, at the three week mark to start active rehab, and then another 3 weeks later to take away my left side and rely solely on the right, that was the right amount of time for me
Yeah.
personally.
And I think I kind of echo the sentiment that you're sharing, which is that it's a very personal decision, and there is a setback and there is a functional loss, as temporary as it may be. Some people take the perspective that they want to get it over with, so to speak, but that can be fairly debilitating, and that can make that kind of dark period that you talked about. Some people aren't sure what that is going to be when they request that. Definitely a more conservative thing is to do one side and retain function on the other limb so that you can still perform some tasks independently and still have something to work with. Yeah.
I believe both Jordan and Leslie are here, so
Oh, wonderful.
you've been
My whole
able
team.
to.
Great.
Your whole team is here. Your support team is here, so that's great. All right. And maybe we do have a number of therapy staff in the chat. So, what would be helpful from your therapist, Evan, or from therapists who are seeing patients, in terms of when to send people to think about this surgery, or what would the kind of factors be in thinking about sending someone to surgery, or who might we think about referring soon for these surgeries? So,
Yeah. I feel like there's quite a lot of pressure on that ask, but
well, and also for Dr. Crowe.
Yeah. So I think, you know, from a therapy perspective, I'll kind of answer your question in two ways. One is the referral. And so if a therapist is seeing a patient with a spinal cord injury and they're asking questions about surgery, you know, I don't think that there's necessarily too soon a time. I think there is an ideal time to send someone, which is around the 3-month mark, which is kind of favorable because the period of spinal shock and everything and neurologic stability is starting to plateau a little bit more than it was, and so we can kind of have a more educated guess as to how function is progressing. But of course, before that, it's not a waste of time to see patients before that because you get the relationship started early. And then the flip side of that is, when do I like to get therapy involved? And I think if the hand therapists are not already doing something, which is unfortunately the case in some patients, I like to get them hooked up with therapy right away, not only to start with passive motion exercises and strengthening, but to also talk about strategies after surgery. So you have a game plan for what rehab is going to look like, and you have a roadmap for what the post-surgical protocol is going to be.
Is that the specific hand therapist or OT so did you start, Evan, like with a specific hand therapist besides Leslie, or?
I did, yeah,
Okay.
actually. Only briefly. It wasn't a new therapist that I was seeing regularly, but several appointments with specific exercises, rehab exercises that I then took back to Leslie and kind of incorporated into my normal schedule also. Mm-hmm.
Question. How many referrals are you getting for nerve transfers within and outside of our system?
That's a great question, and I think I would have to defer that question to Katie Liu, who is head of our nerve center right now. And she would be certainly the person to ask about referral patterns. I know that it is increasing, and I think that there's been a lot of work done in the last year to sort of bring the prospect of nerve transfers to the public and make it widely known that this is something that we are capable of doing now.
Okay. Great. And do you know if that's a lot of individuals with SCI, or is it a lot of other?
It's a mix. It's certainly a mix, but I think that patients with spinal cord injuries, just like Evan, are starting to find out about this earlier in their injury. So, you know, even though that these procedures have been around for 5-10 years, they're just not widely known. And I think we're starting to reach that critical point where it's known enough that people know how and when to refer.
And we have another question. What is the difference between TMR and nerve transfer?
Yeah, so TMR is a technique typically used for patients who have amputations in order to take nerves that were doing one function and move them into muscle that is higher up to give it a new function. That can be used for pain control to prevent neuroma formation, so for like residual limb pain, and it can also be used to then power new muscle and be detected by surface EMG for myoelectric prosthesis as well. So there's several applications of TMR, but not something that we typically employ in a spinal cord population. But a very similar concept to a nerve transfer. It really is a nerve transfer.
Yeah, that makes a lot of sense. But it sounds like you're taking a lower down nerve and going
That's right.
higher,
Yeah,
which
for the
might
most
not be
part.
as useful.
Yeah.
Are insurance companies covering the cost of surgery and rehab?
Typically, these are very, very functional procedures, and so insurance should cover these just as they do tendon transfers. There's enough literature to show that this is not experimental at this point. So.
Okay.
That was true in my case.
Question, I believe, for Evan, how often are you seeing therapies, or maybe kind of early on, how often, and now, how often?
Pre-nerve transfer surgery, it hasn't changed, to be honest. I'm still seeing occupational therapy and physical therapy once a week. I guess briefly there was a time when I was seeing both Leslie and the hand clinic OT at the same time, so maybe twice a week, but I think that got complicated with insurance billing, both coming under occupational therapy. So it was recommended that I just do one or the other for the time being. Yeah, but I haven't increased my therapy frequency.
Okay. Does that sound like a pretty typical pattern, do you know?
It does, and then there are certain points when therapy kind of transitions to more home-based programs and check-ins and things like that, and it's tailored based on proximity and insurance and all those factors. So, yeah.
Okay, that makes sense. And then we have another question. As a rehab therapist, we usually see people for the first month or so post-injury. What would be helpful to know at this stage of recovery? I think in inpatient rehab is, I think, that person's question. What would you want to know at that point? Would it be helpful for us to start bringing up this nerve transfer?
I certainly think so. I mean, it kind of alluding back to my point that there may be ideal points at which we'd like to see patients and are more useful, but there's no point that's too early to sort of start talking about the potential treatments that we have available, and to have some of those conversations, even if we're not making definitive decisions about surgery yet, just to talk about the options out there. So patients that are seen in rehab, inpatient rehab, you can start that conversation of, oh, there's nerve-based procedures and there's tendon-based procedures, and seeing a multidisciplinary team is the way that we can kind of sort those things out.
I feel less strongly about that, but I was introduced to the topic right from the beginning, and it was encouraging to me. But at that point, I didn't even know if I had a complete or an incomplete injury.
Yeah.
I didn't know how much optimism to have after hearing about a surgery like that, because I didn't know if my fingers would open on their own.
Right.
You know, so I guess it was pitched to me at that point as a don't lose hope. Even if you have no, maybe like natural recovery, I guess is a weird way to say it, but even if your function doesn't return normally, that surgery exists for you, and so it was in the back of my mind in that way. But gosh, a 1 month post-injury, I don't think I would have wanted to hear about this yet.
Yeah, that's true, and you might not be in the headspace to sort of know about it, and it may be a conversation that's worth having a little bit later. Yeah.
Both ways.
What level of functioning is necessary to be able to do a nerve transfer? And this person can provide additional information if they want to, but I'm assuming of the muscle, of that nerve and the muscle.
Yeah.
Yeah.
So I think there's a couple ways to answer this. There's very generally, we like to have a muscle that's under voluntary control, and the donor muscle also has to provide strength against resistance. So not just anti-gravity strength, which is enough to lift the weight of the limb, but some resistance, because the stronger that donor muscle is, the better the outcome is going to be when you transfer it. For tendon transfers, we typically say that strength is downgraded 1 grade. So if it was strength with resistance, then it will go down to just anti-gravity strength. Then to get a little bit more specific, and it's sometimes hard to answer these questions without knowing, the complete picture, and that can get complicated. The supinator nerve, like I said, is a common donor, so knowing that that's available. It all kind of ties back into the priorities of reconstruction, because we first want to make sure that elbow extension is possible, then wrist extension, and sometimes we have to end at wrist extension. Sometimes there's just not enough donor nerve or muscle to go beyond that. But as long as we can find some working nerve or muscle in the vicinity, we can do a transfer of some kind, and then we can go beyond those priority, the priority of wrist extension, if there is more donor available. Yeah.
And it sounds like in terms of like the classification you have, or sort of the spinal cord injury classification, you would need to have at least some biceps function to do a surgery, not only, for example, like shoulder shrug and some shoulder.
So for that example, like an intact bicep or an absent biceps would indicate a fairly high level of injury with not much available below the elbow. Yeah.
But again, thank you guys so much for being here. I think we really appreciated it and learned a lot. And I think this will be a great resource going forward for both the presentation itself and the clinic being available for people to look into. Thank you all for being here, and don't forget to fill out the survey, join our listserv, etc., and have a great evening.